Winter with one of your instructor's pet peeves: bone repair. So let me start by telling you that a fracture and a break are exactly the same thing. If you break a bone, you fracture it. If you fracture a bone, you have broken it. During youth, most of those fractures result from trauma. However, in old age, many of them result from a weakness of the bone due to bone thinning. So we can classify fractures by the position of the bone ends after the fracture, the completeness of the break, and whether or not the skin is penetrated. So position of the fracture can be displaced or non-displaced. So if the bone looks like it's in its normal position, the ends are together, that would be non-displaced. If they are out of alignment, then they are displaced. If its bone is broken all the way through, it's a complete fracture. If it's not all the way through, it's an incomplete fracture. And whether the skin is penetrated or not, we have an open or compound fracture, the skin is broken, or a simple or closed fracture, the skin is not broken. We can also describe the location of the fracture, the external appearance, and the nature of the break. So there are a number of different ways to classify fractures and breaks. So some common ones, we have comminuted, where we have bone broken into several pieces. A compression fracture would be the crushing of a bone. Spiral fractures are a result of a twist that occurs. That's a common sports injury when you are changing directions very quickly. Epiphyseal fractures are dangerous because they occur along the epiphyseal plate, and that can interfere with growth of the bone. Depressed fracture would bone be pressing inward. Green stick fracture is like breaking a new so-called green piece of wood. It's one side remains intact, the other side kind of splinters. So to treat a fracture, if it is displaced, it will involve reduction, which is realigning the broken ends of the bone. That can be done by a closed reduction if a physician can manipulate the bones back into correct position without doing any surgical intervention, or an open reduction if you have to go in, cut the skin, and put them back together, usually with pins or wires to secure the ends. Following the reduction, the bone needs to be immobilized so that it maintains the correct shape for healing, and that time needed is going to depend on how bad the break is, which bone is broken, and the age of the patient. Younger patients tend to heal more quickly. Repair is going to involve 4 major stages: hematoma formation, fibrocartilaginous callus formation, bony callus formation, and then finally bone remodeling. This is going to be very similar to some of this to making the bones to begin with. So as soon as the blood vessels are torn, hemorrhages occur, bleeding occurs, clotted blood forms, forming a hematoma, which leads to inflammation. The site becomes swollen, painful, and inflamed. So here we have hematoma forming around the area of the break. This looks like a closed, non-reduced fracture. Next, a fibrocartilaginous callus will form. Capillaries will grow into the hematoma. Phagocytic cells will clear the debris. Fibroblasts will come in and secrete collagen fibers that span the break of the connected broken ends. Fibroblasts, cartilage, and osteogenic cells will begin reconstruction of the bone. First, they'll create a cartilage matrix that's going to serve as a model, and then osteoblasts will form spongy bone within that matrix, and this would be referred to as the fibrocartilaginous callus. So now we've replaced that hematoma with fibrocartilaginous callus, which is still quite soft. And that will slowly be replaced by bony callus. Within about a week, new trabeculi will start to appear in that fibrocartilaginous callus. The callus will be converted to bony or hard callus. It's still spongy bone. And that continues for 2 months until a firm union occurs on average. So now we've got some bone tissue joining the two ends together, replacing and then remodeling occurs while that's forming and continues for several months. As you use the bone, the places where stress is applied will get stronger. It'll go back to places where it's not. It'll get weaker. That will also get compact bone laid down to reconstruct the shaft walls. And the final structure will resemble the original structure. And as it begins to respond to mechanical stresses, it will go back to its original form, shown here. So hematoma forms, fibrocartilage, bony callus, and finally remodeling. Disorders of the bones include the ones that we're going to look at include osteomalacia or rickets, osteoporosis, and Paget's disease. So these are imbalances between bone deposit and bone reabsorption. Osteomalacia, bones are poorly mineralized. The osteoid is produced, but calcium salts are not adequately deposited. So we get soft, weak bones, pain upon bearing weight. Rickets is osteomalacia of children. It can result in bowed legs and other bone deformities because the bone ends are enlarged and abnormally long. Generally, this is a vitamin D deficiency. It could also be a calcium deficiency. Osteoporosis is a group of diseases which bone absorption exceeds deposit. So the matrix remains normal, but bone mass declines. This is particularly true of the spongy bone of the spine and neck and femur, meaning that vertebral and hip fractures are common in patients who have osteoporosis. So we can see normal bone here and how different it is from this osteoporotic bone below. Some of the risk factors for osteoporosis are older postmenopausal women, 30% of women age 60 to 70 years, 70% by age 80. Estrogen plays a role in bone density. When estrogen levels drop after menopause, women run a higher risk. We go back and forth all the time between the risk of osteoporosis and risks associated with hormone replacement. Due to testosterone being present, men are less prone to the susceptibility to osteoporosis. Other additional risk factors, things you can do, insufficient exercise to stress the bones. The more bone you have, the more you can afford to lose. Poor calcium and protein in your diet. Smoking, again, never good for anything. There are genetic components to osteoporosis. Hyperthyroidism, diabetes can also exacerbate or add to osteoporosis. Alcohol and certain medications can also lead to problems. Osteoporosis is treated with calcium, vitamin D supplements. Remember, we need vitamin D to absorb calcium. Weight-bearing exercise and hormone replacement therapy. That will slow bone loss but doesn't reverse it. And again, we have risks associated with hormone replacement. There are some drugs. Bisphosphonates decrease osteoclast activity and the number of them. They can partially reverse osteoporosis in the spine. There's a monoclonal antibody, Densumab, that can reduce fractures in men with prostate cancer and improve bone density in the elderly. We can prevent osteoporosis by getting plenty of calcium in our diet in early adulthood, reduce consumption of carbonated beverages and alcohol. Those acids tend to leach minerals from the bone, so decreasing bone density. Lots of weight-bearing exercise, or appropriate weight-bearing exercise, can increase your bone mass above, and that can give you a buffer for old age. Paget's disease is an excessive and haphazard bone deposit and reabsorption that causes bone to grow fast and develop poorly. It's called Pagetic bone. It has a very high ratio of spongy to compact bone and reduced mineralization, usually occurring in the spine, pelvis, femur, and skull. Rarely happens before age 40. Its cause is unknown, possibly related to viral infections. Treatments include calcitonin and bisphosphonates. So here is Pagetic bone versus normal bone. All right, developmentally, the embryonic skeleton ossifies predictably, so we can use skeletal formation from sonograms, preferably not x-rays, to determine fetal age. And most long bones begin to ossify by 8 weeks. Primary ossifications develop by week 12. At birth, our long bones are ossified except at the epiphyses. The epiphyseal plate persists throughout childhood and adolescence. By about age 25, all the bones are completely ossified and skeletal growth ceases. Here is a ossification images of a fetus. In children and adolescents, bone formation is going to exceed resorption. Males have a tendency to have greater mass than females related to the presence of testosterone, as most of our differences between males and females are. As we reach adulthood, bone reabsorption and laying down tend to be balanced. However, eventually, reabsorption will exceed formation. Bone density changes are largely determined by genetics. Gene for vitamin D docking determines the mass early in life and your osteoporosis risk at old age. Bone mass, mineralization, healing ability decrease with age, beginning about the 4th decade, so when you hit 40. Except for the bones of the skull, bone loss is greater in whites and in females. And as I like to end all of these, it still beats the alternative. So, all right, I'm going to end it there. Next week, we'll move on to the axial skeleton.